Ethiopia because of some issues, but we'll come back to you when it's done. Okay. So we'll start with the presentation from Senegal. Determinants of satisfaction among community-based health insurance members in Ethiopia. Sorry. Effects of health insurance on healthcare utilization and inequalities in Senegal. Is our presenter here? No. All right, so we'll skip that. We'll go to NCD reimbursement trends by NHIF in Tanzania. Okay. So sorry, I can't give bios of our presenters, but please give your own bios.
Thank you, Professor Ama. On your behalf, I'll give my bio. Yes, my name is George Ruhago. I'm a senior lecturer in health economics at Muhimbili University in Tanzania. This work we are about to present is part of the project supported by NORAD, but also with our colleagues from University of Bergen, also Castori there from Muhimbili University, but is now starting his PhD at University of Bergen as well, and other colleagues will be coming in that we are working on. And we have like 7 or 9 presentations across this project here. So what we are trying to look at in this study is the NCD reimbursement trend towards universal health coverage in Tanzania, with looking at the claim data from National Health Insurance Fund for 2022-2023. We did this because there was a change of the database from the previous that was used. Then the new one could only give the 2022-23 data. We are still working hard to see if they will be able to get us the previous data, but it has proved difficult. Was using different ICD. It was using ICD-9, and now you're using ICD-10. So linking up the data becomes very complicated. So here, the burden of NCD has been rising in Tanzania. Now it's around 34%. Previously was around 27% cause mortality, and 4 major NCD are the leading cause of NCD-related mortality: cardiovascular disease, diabetic, cancer, and chronic respiratory diseases. But also the country has embarked on UHI, which has made us go back and see the importance of examining the current financial burden, what is ongoing, while we are embarking on the new journey to see what can we do and what cannot do. This has been also a blessing to academicians like us to be able to access the data, because we've been asking for the data for years and years, and nobody was interested to provide the data. But since the information is needed now, we have accessed. As I said, we are trying to look at the claim data to address the UHI issue. And this is this was a cross-sectional study design that used quantitative methodology to look at the secondary data. And beneficiaries who have been registered for at least one claim for major NCD from January 2022 to December 2023, which is equivalent to 2 years, were used, and the claims were identified using the International Statistical Classification Standard, or as known as ICD-10 codes. Can you help me with the next, please? This takes a little bit. So we, in total, we had a total of 15 million NCD claims that were used in the analysis. Data were summarized in the Microsoft Excel, and other software were used for analysis. Next. So rush to the most important part, which is the results. So the median age was around 35, contributing to 66%. In 2022, didn't change a lot. And as you could see, female were more than male, 59/41. Next. So this is how the distribution is Can someone tell me if he's seeing the legend down? Not easy. So the blue one, I'm sorry, I'm colorblind. So if I don't say quite the right color, forgive me. That one, she already told me it's dark blue. The dark blue, and the other one I presume is red. That's diabetes. The dark blue is cardiovascular. Then the next one is chronic renal disease. And the other one, which is a yellow, I think, is cancer. And the blue one now is mental illness. And the green one is chronic respiratory illness. So this is how this CVD continuously was higher at around 67% among the NCD, claimed that it was received, followed by diabetes and chronic renal disease, as well as chronic respiratory disease. Next. But when we look at the distribution of claims by ownership, most of this came from government facilities, which is the blue one, and then the private facilities, which is like 31% there. Faith-based is the green one, and the other one is non-governmental organization, which are fewer. In Tanzania, the distribution is mostly like this. It's government, private, and FBO, which are faith-based hospitals. So it's mainly three, and then others occupy a little bit. But when we look on the level as well, we have several different levels where we have, it starts from primary healthcare that composes of dispensary, health center, and hospital, district hospitals. Then we have regional level, we have zonal hospital, and then we have the highest, which is national hospital or referral, the national hospital. So when you look here, the regional level had the most claims, and the lowest claim came from farmers, because farmers also, people are referred there. But primary healthcare, combining them, the health center and dispensaries had only 4.9%, but this composes almost 60% or 7% of the 10,000 facilities in NHIF claims. Next. So this is the overall trend of reimbursement, whereby the number of visits were around 1.9 million. For 2022, that increased to 2.3, but also the reimbursed amount was 84.7 million, that increased to around 90.7, despite the fact that the average visit per patient remained the same, but the cost increased significantly. It's the same, the average reimbursement in 2022 was 44.9, but that went a little bit down. Next. So this is for specific NCD categories from 2022, and you could see cardiovascular increased significantly, around by 10 points from 39.2% in 2022. The blue one is 2022, the red one is 2023. And then cancers as well, diabetes, a little bit of chronic respiratory illness is the one that went a little bit down, and mental illness. And that could be explained by the fact that most of mental illness are provided in specified hospitals that are funded by the government. Next. When we look on the average reimbursement per visit, cardiovascular disease goes a little bit down. However, the cancers become very expensive in that this is the same as per patient. The cancer is significantly expensive, even though as we saw there were visits were fewer and the numbers were fewer. Still, they are very, very, very expensive to the National Health Insurance Fund. Next. So what are we seeing here is that there is a rise in reimbursement expenses for the primary and communicable diseases, and cardiovascular claims account for the largest number of NCD patient claim. However, cancer and chronic kidney disease are expensive NCDs to treat. And most NCD claims are predominantly sourced from urban area, particularly from private and tertiary health facilities. Next. So what do we recommend in that? NHIF stands there because this study is from Tanzania, but this could be taken for any insurance fund. One is to check if the benefit package could integrate preventive measures for communicable diseases, but also if we could have focused approach of reimbursing NCD claims, in which devising the payment method for providers. As we speak now, currently, this has been done in Tanzania since we presented this study, and there's been a significance downward on the claim because there was also not a clear way of following them. However, prioritizing cost-effective NCD interventions and the referral systems. As we saw, the primary health facilities that are cheaper, they could treat most NCD cheaply, but people don't prefer to go there. So we need to have efforts in which most NCDs can be treated in rural health facilities that will prevent having more complex cases at the high level, which could save quite a lot of resources. And we will look on that as we continue doing this. Thank you very much.
Thank you very much. Thank you very much for this. I know we have a lot of questions, but let's take all the presentations and then we'll come back and talk about them. So keep your questions on hand. We'll call you when it's time. We'll have our next presentation, and this is on determinants of satisfaction among CBHI members in Ethiopia. I'll call on Dr. Mr. Adamu Tekahu from the Ethiopia Health Insurance Service to give this presentation. Please, can you give us a brief bio when you start? Since I don't have the bios, please.
Okay, thank you. Good afternoon, everybody. I think, yeah. So I think this it is a thank for the Rwandan colleagues and teams to get this privilege to present our research that as Ethiopia context, we will to, I think, different data will provide with different source of the report, but according to my research, Ethiopian population is around 150 million population. I think, you know, the second in Africa continent, and the life expectancy birth is 66.5 years, and also the gross domestic product per capita is 936. As health insurance, health finance issue, I think it is low in many African countries, and also in Ethiopia, also it is very low, $36 per health expenditure, and also there is high out of pocket at national level even, and also high dependence on donors' dependence on the health system, and inadequate allocation of government budget, which are not reached to the declaration. I think global declaration is still not achieved. Less than 8% that's general government allocation for the health sector. This is a report from World Bank. When you see the community-based health insurance in Ethiopia, I think unfortunately we are not implementing social insurance. We are implementing the community-based health insurance in the country, and from the total district, almost 1,054 district, or 80% of the total district coverage in the at nationwide, and also I think more than 12 million households are joining the CBHI program, and also more than 54 million population of the country benefit from the program. This is the HIS report, Ethiopian Health Insurance Service report 2024. When we come to the, I think the presentation, I think we will be the objective, methodology, finding, and also conclusion and recommendation. The objective, major objective is the determinant of the topic is the determinant of satisfaction regarding to the CBHI program. It is largely implemented in the country, and we measure the level of awareness of CBHI members regarding to the CBHI program, and also what are their major perception regarding to the programs, and also the determinant, what are the main determinant factors for satisfaction of CBHI members, as well as finally it is a recommendation, actually a recommendation to satisfy the CBHI members. When we see the methodology, I think we can see that it's a cross-sectional study design method, and this finding is from the national study, and also it is cross-sectional study design approach, and also multi-stage stratified sampling technique, because it's done in the 13 regional states, and Ethiopia has totally 14 regional states, but unfortunately, the security issue, only 30 regionals are addressed by this study, which is multi-stage stratified sampling system. we use, and also the sample size household level is more than 4,000 households are addressed by this study. And I think there is a stratification between urban and urban population, and also the district, which have, I think the major stratification is district level and household level is the data collection tool is, I think, structured questionnaire and trained professionals. Majority of the data collector is, I think, degree level holder, and the methods of data analysis, descriptive inferential statistics, and logos regression, as well as finally we use multivariate predictor to find the predictors. When we to come to the major finding, I think regarding to the awareness, there are different items. Questionnaires were developed to measure the level of awareness about the CVHI program. Is all citizens who are joining the CVHI program aware about the program, aware about the benefit, and also how they aware and how they get this awareness was assessed. And the major finding from the study is that public meeting, house visit, and also facility, I think morning teaching is the main source of awareness for the community. We invest a lot on the mass media, but the mass media channel for communication of CVHI program not that much addressed. So public meeting and house is a major one to address the community. If the citizens didn't have aware of it, the CVHI program, it is difficult to continue their membership and annual renewal. So this is a major finding. When you see the rural and urban, there is some difference, but still the awareness level between the mass media health facility, I think, is similar finding. When we see the overall awareness about CVHI program, a CVHI program is operation level for the registration process, the ID process, and the benefit package, blah, blah, blah. Awareness level by membership type, majority is aware by the paying member regarding to the indigent, because most of the times the indigent is covered by the government, local government, regional, state, district, and zonal government allocates for the indigent. So I think the awareness level of indigent is still low than the paying member. Nationally is 64% between the membership. When we see the gender, I think there is no much difference regarding to the awareness level between the genders, and by awareness level by age category, I think also similar. When we go to the older pupils are not joining the public meeting, as well as the training session, maybe the main reason to not address. Awareness level increase with duration of enrollment and also the education level. Well, as you see, awareness by a number of the years, so I think 7 to 9 years and above 9 years is more aware somehow, but at 7 and 9 years, I think more aware if they join after joining the CVHI program. Regarding to the education, educated pupils are more aware than, and I think low educated pupils, because as you see, the secondary TVT and the diploma and above educated pupils are more aware than the others. When you see the perception, I think the overall perception is, I think, a different category. I think composite variables also used for all the items. The positive perception of from the total is 58%. The other is, I think, this is negative perception. Why perception comes? This is that the overall perception by social demographic, rural and urban, is some difference with the perception of the population. Perception by age, I think, similarly in the early age groups are low perception than the older age, maybe due to the experience of joining the program. Overall perception by social demographic, the paying and indigent is somehow still similar with awareness, because the indigent population are covered by the local government and also regional government. So majority of the time they may join the awareness public meeting and like that, so it is still low. There is no difference between the male and female perception. In general, the study showed that 68% of the respondents were satisfied with SPHA program in general. But at the national level, the strategy said we planned to reach 85%, but still it is not reach the national targets. And I think member in urban area are less satisfied than rural most of the time, because I think rural area are most less satisfied with CBHI program. No difference between age, sex, marital status, and also membership types. When you see the main finding in relation to the satisfaction level, I think you see from the table that member perception is 3.79 more times more likely to be satisfied than I think the negative perception. I think this is the major determinant also for the satisfaction. Where we see the awareness level, those who have good awareness, those who have good awareness about CVHI program, registration process, benefit package, all of the benefit of the program is one. I think those who have good awareness 1.31 times more likely to be satisfied than those who have low awareness. Those who use the CVHI ID card to utilize the health services, I think still almost better 1.33 times more likely to be satisfied because they are experienced. Yeah. When we see the conclusion recommendation, I think the major conclusion is that the overall satisfaction of national satisfaction target not achieved yet, and also the significant predictor of satisfaction is awareness, perception, as well as resident enrollment and also utilization. The main recommendation is that awareness creation should be disseminate successful story experience for the community is one of the better to during the public meeting as well as house to house visit. Service availability also, I think one of the satisfaction determinants. So it should be avoid out of pocket, otherwise it is difficult. The third one is, I think, improve the health quality service, especially the availability of quality service to the CBHI beneficiary is one of the recommendation. Finally, I think CBHI beneficiary, a number of expectation expected, so we should address to join and sustain in the program, I think. Thank you for very much.
Thank you very much for the presentation and for doing it in good time. So we're going to carry on with the next presentation from Nigeria. I'm not sure if our presenter is here. Oh, you're here. Oh, okay. Elaine. All right. So as I said, this presentation will be fiscal space analysis and the Vulnerable Group Fund in Nigeria. Please give us your bio. Thank you.
Thank you very much. Good afternoon, everyone. My name is Bolanle Olusola Faleye. I'm a public health physician. I'm a fellow of the Nigerian National Postgraduate Medical College. And I've been working in the space of health system strengthening, private sector engagement, health financing, TB/HIV collaboration, and community health services for a while. So what I'm presenting this afternoon is the study conducted by APT Global under the USAID Local Health System Sustainability Program, LHSS, to analyze the fiscal space available for Nigeria's Vulnerable Group Fund. To give you some context, the National Health Insurance Authority Act of 2022 made health insurance mandatory in Nigeria. And we do know that to implement mandatory health insurance, premium subsidization for the poor is critical. And so that law also introduces the Vulnerable Group Fund, thereby fulfilling the two legal requirements for achieving universal health insurance coverage, that is mandatory participation and premium subsidization for the poor. That law also identified the potential sources for funding the Vulnerable Group Fund, namely the Basic Healthcare Provision Fund, health insurance levies, special intervention funds, interest from investments, grants, donations, gifts, and voluntary contributions. Now, the Vulnerable Group Fund assumed even more relevance of recent with the Nigerian health reforms. That is the Nigerian Health Sector Renewal Investment Initiative that identifies VGF as a major component alongside other initiatives like community-based service delivery, decentralized facility financing, secondary care, and medical and public health emergency fund. Now, VGF is justified by the high out-of-pocket expenditure in Nigeria, unacceptably high at over 70%. And of course, it has the potential to resolve the disparities in healthcare access between the rich and poor Nigerians. We do know that in Nigeria, women of the higher socioeconomic group are 10 times more likely to have skilled birth attendant at delivery. And children in the lowest socioeconomic group are 3 times more likely to die before their 5th birthday than those who are in the higher socioeconomic group. So VGF could be the answer that we need to resolve those disparities and enable equity in Nigeria. For some economic context, our economic situation is not very rosy right now. Nigeria uses about 73% of its revenue to service debt. That's our debt service to revenue ratio. It's unacceptably high, we know. And that implies about 3/4 of our revenue is used to service debts. So there's stiff competition for scarce government resources. And so apart from budgetary allocations, which the National Health Insurance Authority got, for 2024 for VGF about 5 billion naira, the NHI needs to get innovative and explore more innovative ways of raising and mobilizing revenue for the Vulnerable Group Fund if we are to cover the 83 million Nigerians that this fund was established to cover. So what we did was to conduct a fiscal space analysis using Peter Eller's 2006 model for conducting fiscal space analysis. It has 5 components. The first is economic growth, or what we call macroeconomic dynamics. The second is budget prioritization. The third is earmarking revenues. The fourth is savings from efficiency. And the fifth, of course, is external financing. This graph on the right already shows you some shiny objects because we actually looked at a number of potential revenue sources using these 5 pillars. The Basic Healthcare Provision Fund, I'm going to spend a little time on it because that's already ongoing. Some of us are very familiar with it. We already have that. Right now, the law says at least 1% of the Nigerian Consolidated Revenue Fund should be earmarked for the Basic Healthcare Provision Fund. The National Health Insurance Authority gets about 48.75% of the entire fund. We're at 1% right now, but the law says at least 1%. And so there's a potential to increase that to 2%. And if we do that, we can get 64 billion naira based on the portion that is allocated to the NHI. We looked at pro-health taxes for alcohol, for tobacco, for sugar-sweetened beverages. We looked at diaspora remittances, very shiny. We looked at telecommunication taxes. And then we looked at earmarking a particular percentage of the value-added tax, that's VAT, for health insurance and for the Vulnerable Group Fund. The shiny objects here are clear, right? So the diaspora remittances, which is the money that gets, taxed by international corporations for the money that Nigerians overseas send to Nigerians at home. That is diaspora remittances. And this fund seems to have the highest potential of raising revenue for the VGF if earmarked and if advocated for at international level. And for our information, the NHI did talk to the Chatham House a couple of years ago to look at how we can help us with advocacy. That some of the money Nigerians abroad, including the doctors that we're exporting in masses every year, sent home to build the health system in Nigeria. You see that next to that is the value-added tax. We looked at 2 scenarios. If the NHIA gets 0.25% of the 7.5% VAT, for the Vulnerable Group Fund, we'll get the next highest amount at 168 billion naira. If we get to 0.5%, that's 168 billion. If it is 0.25 at the minimum, that will give us 84 billion. But higher than that is the pro-health tax on alcohol. Nigerians do drink. And so if you do that, you can actually get 134 billion for the Vulnerable Group Fund. These are the results that we got just by conducting fiscal space analysis using Peter Eller's model. However, we can't be blinded by shiny objects, right? We need to get practical, focused, and political. Not everything is doable, and definitely not at the same time or at the same rate. So let's look at these 5 pillars again from Peter Eller's model. The economic growth is not within the control of the Ministry of Health. It determines a lot of things, but the Ministry of Health may not be able to do anything about Nigeria's macroeconomic development. But the MOH can advocate for budget prioritization. That declaration to allocate at least 50% of budgets to health was made right there in Nigeria, in Abuja. But right now, our budget for 2025 still put it as less than 7%. We had gone above 7% before. We are 6.7 thereabout now, but it is still more money, compared to last year's budget in absolute figures. But then we can also, advocate for earmarking revenues, those pro-L taxes, the VAT, the telecommunication taxes, which almost, by the way, made into that law in 2022, was removed at the last minute for political economy reasons. All right, the MOH can also become more efficient in the way we implement activities, that is the health sector as a whole, not just the Ministry of Health, better use of resources, and also policies. When we talk about efficiency, we sometimes focus only on financial efficiency, forgetting there's also policy inefficiency. When you have policies that you are not using or implementing or leveraging to get the resources that you need. So a good fiscal space analysis will include political economy analysis that look at the feasibility of all of this. To create the right narrative and build trust and transparency, we first developed a virtuous cycle for the VGF, not a vicious cycle, but a virtuous one that will make the VGF appealing to those that can help us in the health sector to get the resources that we need. Let's start from the mobilizing fund. Assuming we get whatever we want right now, whatever we can get right now, including last year of 5 billion naira, and then we use it efficiently, effectively, and then we can demonstrate results, evidence-based results. Sometimes we actually have results, but we don't demonstrate them well. We don't report them well. So there has to be an intentional plan to show evidence of effective and efficient use of whatever we have right now. And then this will strengthen the rationale for increased financing. We can then ask for additional resources, showing that we have used what we have gotten so far very well. And then we can mobilize more resources, and then we can use them even better, and then we have more evidence, then we can justify more, and then we can get more resources, and the cycle goes on and on. This is our virtuous cycle that we plan to work with the NHI to implement. Now, to do this successfully, we need to engage stakeholders. They are critical. On the left side, we have those stakeholders that can help the NHI to mobilize funding for VGF. They include, of course, first on the list, the Ministry of Finance, the legislature, other line ministries, like this Ministry for Social Protection has funding that they call special intervention, programs that the NHI can actually leverage on. There was a scenario we used where we said, okay, what if we get 20% of the money that goes to this ministry? Because health is a critical part of social welfare, right? And then we have even the media, civil society, and the private sector. On the right, we have the stakeholders that will help the NHI to demonstrate efficient and judicious use of the VGF. Top on the list is the National Primary Health Care Development Agency. We do know that when the demand side needs to grow, the supply side has to be strong to market the scheme. The National Primary Care Development Agency and its state agencies and boards are critical to NHI's virtuous cycle to demonstrate effective use of the VGF. We also have the Ministry of Health. We have the state health insurance agencies, because we have 36 plus 1, 37 of them. And then the vulnerable groups themselves in the communities are critical stakeholders, because if they don't use the services, then we cannot demonstrate impact or even outcomes on the short run. These are the stakeholders that the NHI would need. And so we use all of this information to create a VGF or fiscal space expansion strategy. The accountability framework is the first stage, where we must have a way of not only demonstrating, but also proving that we are accountable and transparent. So accountability framework at the barest minimum will be required. Then health priority alignment. The president of Nigeria did include in its campaign manifesto that will work towards having about 40% of Nigerians be on health insurance. And so already NHI is priority. And the NHI has been enjoying some of these, dividends of the promise, prioritization in terms of giving more attention and even boasting with the result that we have so far. Aligning with the SWAP initiative is also critical. The SWAP, approach is what the Nigerian health sector is using to drive its reform. And using SWAP will be an advantage for the NHI to get more resources for the Vulnerable Group Fund. Political economy analysis is very critical, where we look at who our stakeholders are, their interests, what motivates them, what do we need to get them on our side. And then the investment case development is very important. We have to make a health investment case for the Vulnerable Group Fund. We have to make an economic investment case. We have to make a political investment case and a social investment case for VGF. And this will constitute our fiscal space expansion strategy, working with all the stakeholders that we have seen on the previous slide. And then we looked at the numbers, using all this information that we have to create a stepwise approach to how they can become, realistic. At the basic minimum, at baseline, we need to demonstrate more accountability, including the capacity to track expenditure, enrollment, and utilization. All three are critical at the baseline right now as we go forward. In the short term, we can now demonstrate the increased efficiency from system strengthening. A case in point is the Basic Healthcare Provision Fund, where states used to have a lot of money in their account, especially for fee-for-service that were not expended, and there were people waiting to be enrolled. The NHI has stepped in to correct some of these wrongs, and we believe that in the next couple of years, we'll see a lot of efficiency gains in that regard by strengthening our PFM system. Also, a lot of our states in Nigeria have it in their laws to, pay equity fund. Apart from the Vulnerable Group Fund, the state equity fund can be part of that pool in the spirit of SWAP. So they have it in their laws to pay equity fund through their own state health insurance agencies. And many of these states also have it that the local government area should also pay equity fund. And we are leveraging this in some states like Nasarawa, like in Plateau. If only 50% of our states can pay both state level and LG equity fund in the next 2 to 3 years, we're going to have a lot of resources for the VGF. The numbers that this translates to in number of lives covered will be seen on the next slide. In the medium term, when we get bolder, let's imagine that all the states, we have platforms, a Joint Governors Forum, where these states can actually compete, in a healthy way. Assuming 100% of them all pay the state and LG equity fund, we get more money. The adoption model is something a lot of governors are proud of because it's a political gain for them. They adopt 1,000 lives. Their commissioners adopt, 1,000 lives. The government chairman adopt lives. If all of this is formalized and led by the NHIA, we will get more money. And then increased financing and absorption, which is critical, must also be planned, in the whole stakeholder engagement and expansion strategy. In the long term, we can actually have legal frameworks. Well, we know some of the earmarks need legal frameworks to work. That is why we put it in maybe 3, 5, 10 years. We can have legal frameworks for earmarks from VAT, from telecommunication, and even from pro-health taxes. And these are the numbers in terms of number of lives. At baseline, this number has since increased to 2 million people covered under the Basic Healthcare Provision Fund. This is where we are. In 2 to 3 years, if we implement these things that mentioned earlier, state and LJ contribution, efficiency, and we included BACPF earmark going up midway to 1.5%, then we can have as many as 6.6 million Nigerians covered under the Vulnerable Group Fund, which is a big shift from where we are right now at about 2 million. In the medium term, when we have more earmarks, maybe like telecommunication, because that almost made it into the law, VAT earmarks, social reduction programs, you can actually cover as many as 18 million additional people out of the 83 million Nigerians that are poor and vulnerable. In the long term, when we are able to add the pro-health taxes, for example, and even tax earmarks that we have in Ghana, we can actually have about 57 million Nigerians covered by the Vulnerable Group Fund. We had experience today from Rwanda about how they expanded their community-based insurance pool by getting just earmarks from a pump sale of petrol and also the telecommunication tax. And we can do the same. We know we need a legal framework, and that's why we are putting it between medium and long-term plan. In conclusion, all these numbers will be meaningful when we're able to demonstrate a virtuous cycle. That is the critical point of this presentation. We need to make better use of not only resources, but policies. We need to look outside the health sector at other people that can help us in the Ministry of Finance, in the Ministry of Transportation, in the Ministry of Poverty Alleviation, and Women Affairs. We need to collaborate on health and advocacy. And we need to demonstrate this use with clear evidence that connect to the stakeholders' objectives. Remember, we cannot keep putting water in a leaking bucket. When people don't trust our systems, they will not put funds into what we need to improve the health coverage for our people. The SWAP initiative is what Nigeria is implementing right now. Health insurance coverage is a priority for the government, and we must align with our stakeholders' objectives and interests in the spirit of improving health outcomes for our country. Thank you so much for your time, acknowledging the NHIA and our partner, DGI Consult. Thank you.
Thank you very much, Dr. Olanle. Please keep your questions. I do have a few, so please keep your questions. We'll have time for questions. Our last presentation today for this session will be private sector engagement in national health insurance schemes. And this will be from LSE, the team from LSE. Please give us your bio. And you may need to project, even though this.
Okay. Good afternoon, everyone. Yeah. My name is Suleiman Yakubu. I am a health system strengthening specialist, also with a background in health financing and private sector engagement in healthcare, with the goal of improving universal health coverage and health equity. For this presentation, we're looking at examining private sector engagement in national health insurance schemes to achieve UHC in sub-Saharan Africa. We're focusing on 2 countries for this as our case study for this presentation, Nigeria and Kenya. And this work is being done by the LSC as part of the AHOP, African Health Observatory Platform. For the introduction, like we all know, across sub-Saharan Africa, there's the need for countries to, and also desire to achieve universal health coverage, particularly targeting the underserved populations and vulnerable populations. And as part of, there are still challenges, and it's still really a very long journey, but we're beginning to see the role of improving regulation as part of this process, particularly looking at the role of the National Health Insurance Scheme and health insurance as a pathway towards achieving UHC. And we've seen some successes in Nigeria and also Kenya, but also across sub-Saharan Africa. And there's a big role of the private sector in this in terms of their role in delivering healthcare services, looking at underserved population. So that's what this particular presentation is going to be focused on. And we recognize the role of key stakeholders, the Ministry of Health in country as part of their role in terms of stewardship, improving accountability, but also in engaging other stakeholders. The role of service providers, both in the formal setting, but also informal setting, in government healthcare facilities, and health management organizations play also a big role. And like the last presentation, the role of the community that's involved in this, which involves insured but also uninsured population. Like I said, this particular presentation is focused on the role of the private sector, recognizing their key role, and also the number of the quality of services they provide, across these countries, how they fill gaps in providing healthcare services, but also bringing in some form of innovation and efficiency in delivering quality healthcare services. However, there are still gaps. Private sector, more generally, has like a lot of pluses, but also there are challenges in the healthcare service provision. Some of them are, because they're private sector service providers, there's also issue around having a profit motive. So there's usually mistrust in providing healthcare services. But also we've seen that the community, there's also trust from the community to engage with the private sector, to go to the private sector because of the kind of models or the efficiencies they bring in delivering healthcare services in these areas. We've also seen the role of improved regulation and how that really works in engaging the private sector to ensure that they deliver quality services, and where there's good stewardship and also accountability and engagement of the private sector, we've seen that it has been a very proper handshake and good collaboration between public and private. And that has also helped in filling gaps. But more importantly, also in terms of barriers, there are key issues around financial incentives, which is very critical to the private sector. And when this is lacking, most times there's that limited engagement. For this particular study, like I said, it's focused on sub-Saharan Africa, but we're looking at two cases in particular, Nigeria, Kenya, because of their unique, the number of population they have in Nigeria and being one of the largest countries in Africa, but also the number of lives. But Kenya in East Africa, and also some of the innovations they bring in delivering quality healthcare services. So for this particular study, we've used a mixed method approach, looking at literature reviews, looking at policies, particularly health financing policies, but also other health system strengthening policies and frameworks that have been interviewed. And we've also engaged with conducting qualitative key informative interviews with key stakeholders, both at the national level, within government, the health insurance schemes, looking at the different policies that exist and also the experience with engaging with the private sector, but also the private healthcare providers themselves, both at the facility level, but also as an association. So Nigeria and also in Kenya, they are a form association within the private sector, which also enables them to engage with government. And we've seen that to be a good form of engagement. Other countries that's part of this particular work involves Rwanda, Ethiopia, Kenya, and Senegal. For this particular study, our working definition of the private sector involves non-state actors who provide healthcare services, and which can be for-profit, both in formal and informal settings, but also non-profit. We've seen faith-based organizations like the Christian Health Association, for example, and in Nigeria, we've had cases of Form 1, the Federation of Muslim Association play a big role, but also community-based organizations. And for private sector engagement, this also refers to meaningful engagement. In the past, we've seen that there's been some form of interactions between public and private, but there hasn't been a focused engagement. But more recently, we're beginning to see that develop across these countries we're focusing on, which is a good thing, and we feel it's a good step towards advancing towards UHC. For this study, we recognize the framework WHO has developed, which is looking at the governance framework for engaging in private sector, making sure that there's very good stewardship and accountability. And this really sits at the heart of towards strengthening healthcare systems to become more resilient, by making sure that all stakeholders are involved, using the all hands on deck approach to engage. And we've seen that if the structures are really aligned, if there's trust and accountability across partners, we see that services are usually of very good quality, but also the patients get good experience of care when they access it. Regulatory mechanisms, we've seen across the different countries we've been looking at, we've seen that having a very good and strengthened regulation is very important in terms of engaging the private sector. And we recognize the role of national agencies, and also across these countries, there are sub-national agencies like the National Health Insurance Agency in Nigeria, but also the National Health Insurance Fund in Kenya as well. And across Nigeria, it's also helpful to recognize that there are health insurance agencies who provide some regulation to private sector. And we've seen this to become really well as part of a decentralization effort. For our analysis, we've looked at key strategies that has really enhanced this private sector engagement, which requires looking at accreditation and tariff negotiation. As part of the framework we're looking at, we've seen that the role of, when there's very clear negotiation in terms of incentives and different funding mechanisms that needs to be provided, there is a balanced interaction between the public and the private sector. Also, we've looked at the role of provider awareness, which is very high in Nigeria. As part of the stakeholders we consulted, particularly from the private healthcare providers, we've seen that there's high awareness, but also similarly in Kenya, but also there needs to be more improvement in that regard. We've seen also training in terms of capacity building of private healthcare providers to deliver quality services, but also more importantly, to be aware of what the different policies and regulations the health insurance agencies have, also helps them to engage better. Then also payment, particularly, it's very important to the private sector, particularly private sector that for profits. It's very critical, and when there's good payment mechanism, it helps the private sector to build trust and also accountability and addresses other barriers. For enablers, like I listed earlier, we've seen that also when there's this financial incentives and stability, and for finance, more importantly, because of just building on the previous presentation, given the economic landscape, we've seen that there's been high inflation. So when this is taken into recognition, the private sector is also really inspired. But also in Nigeria, that effort needs to be really tackled and looked into in terms of looking at the prevailing inflation rates, and also recognize that most of the tariffs, particularly fee for service or capitation, has to be recognized, all of this work. Regulatory frameworks, where there is very good regulatory framework like we've seen in Nigeria, it helps to engage with the private sector. But sometimes when there's lack of the presence of these frameworks or understanding the frameworks, the private sector tends to also mistrust the process because it feels like the goalpost, for example, keeps shifting every time with the different regulatory mechanisms. And we've seen the role of technology, particularly engaging with the private sector in terms of their registration, but also accreditation process. We've seen digital innovation play a big role to advance this particular area. But more importantly, monitoring and accountability. And when there's very good quality regulatory and also monitoring, as well as oversight mechanism in terms of going to the private healthcare facilities to monitor with good spirit and good intentions, because most times it feels like the private sector from the interaction feels like a witch hunt rather than just a meaningful, supportive or supervisory kind of visit. So that also can be a barrier in itself. But if it's done properly, it can be also a very good enabler. But just also looking at the same areas also, like I listed earlier, some of the barriers can also be low billing rates, late payments of the fees to the private sector players, but also low reimbursements also can be also a big disincentive for private sector to engage with the national health insurance. Operational inefficiencies can also be a very big bottleneck. We've seen bureaucratic hurdles being a big challenge. By this, I mean, sometimes it takes a long time to really get either feedback or being included as part of the process for private sector to engage. And from our conversation with the private sector, they just want to have a very meaningful conversation. Communication is very key. They want to be treated with respect, and they want to be engaged properly as partners rather than seen as just being a subordinate. So I think that's also very important. But more importantly, I think they want to be included in policy development, but also dissemination of some of the strategies and plans that exist. Just to wrap up, in summary, I think we've seen that private sector can play a very big role. Across sub-Saharan Africa, private sector delivers a substantial and also significant services to the population, particularly the vulnerable population. If we need to advance and also achieve universal health coverage, the private sector will be a critical stakeholder, and they are a critical stakeholder, and they need to be engaged critically. There needs to be proper awareness and training, but also there needs to be mutual negotiation in terms of understanding what tariffs is and recognizing that the economic climate also affects the healthcare provision, and healthcare is a business, so and it needs to be treated as such. And for engagement, the health insurance plays a big role, and we see that if we have this meaningful engagement, it's going to advance towards UHC. And in terms of policies, like I said earlier, there needs to be proper financial incentives for the private sector to really be bought in, not because they're profit-driven, but because healthcare is a business and it's very important, so it has to be treated as such. And there has to be timely reimbursements. And so in terms of recommendations, our team have looked really broadly and seen that there has to be adjustments in looking at the economic situation across the region, inflation being a particular one, and this has to be reflected in the costs of service provision. And there has to be enhanced training. It shouldn't just be focused on public healthcare facilities, but also looking at the role the private sector plays, and they have to be a critical stakeholder in this. There has to be the promotion of technology, particularly digital innovation. We've seen digital technology, taking off, and this has to be incorporated into the engagement with private sector. And monitoring accountability, and it has to be done with mutual recognition, respect, and there has to be clear accountability and purpose for why it's been done, rather than looking at it from a witch hunt kind of perspective. Thank you very much. I'd like to acknowledge our team, Professor Lucy Kanya, who's leading this particular effort, but also my other colleague, Dr. Swati Iya, who isn't here, but also has been fully engaged in this process. But more importantly, the leaders of the AHOP, and I would like to thank the rest member of the team for their support. Thank you.
Thank you very much. We've had 4 very rich presentations this afternoon. Can I have all our presenters come up front? Please join us here at the front. We have a number of questions for you because I think you've given us a lot of things to think about. Health insurance, health financing, the issues are plenty. And we're here to ask you how and why. We'll start on this side. Any questions from this side for the panelists? We've heard from Ethiopia. We've heard, yes.
Thank you so much. Yeah. Thank you so much. You did a good presentation. And I would like to ask about. Sorry?
So the mic won't make you louder, but it will allow us to be able to do interpretation. So speak loud, project your own voice. Yeah. But speak into the mic because we need to do interpretation.
Okay.
Yes.
Okay, thank you so much. You did a good presentation. I would like to know more about national health insurance in Nigeria. Yeah. How is I would like to know the structure, how they see your CBHI is structured, especially in pooling. How do you're talking about collecting contributions, and how do you collect it? And also, I would like to know about the benefit package. How do you provide once those CBHI members pay their contributions? What is the package, the health package that you are providing? And the last one is about vulnerable people. I saw different partners who are supporting. How do you select those vulnerable people? Is it the partner who are bringing the name of, or is the government who selects those vulnerable people so that they can receive service, they can be get support from?
Dr. Lale, please keep the questions. I'm sure more will come. I'll go to this lady and go to her. Please, can you pass?
Thank you so much to the presenters. My apologies, I came in late, so I may ask a question that was already answered in your slides. I'm from Malawi, Emirates Era. We are just implementing our newly launched health financing strategy, and NHI is one of the things that we are grappling with. I learned about Ghana, and I noted that a huge chunk of the funds within their NHI is still taxes. I want to understand how is it like in Nigeria. This morning I was in a panel, and a lady shared with us that 77% is out of pocket in Nigeria. So for me, I thought it's an opportunity that people are already paying, people are already willing to pay, and people will quickly jump on an NHI insurance, be it private or NHI. I want to understand how the 77% now links with the NHI. Are people willing to join? How many people have joined? I just wanted to make sense of that figure and see if it makes meaning in as far as your NHI is concerned.
Yeah, good afternoon. Okaka from Kenya, teach at a university. I would like to know from the Nigerian experience. You are isolating people who cannot pay. I assume they are indigent. How do you select? Because there is a problem with that, and sometimes that if you have a cutoff, people will keep shifting from year to year, and then it becomes very difficult to earmark those people who you are supposed to pay for and those who are not supposed to pay for. And lastly, I've forgotten his name. It's difficult. The panelist who presented on private health. In Kenya, I'm from Kenya, the situation is, and you talked about Kenya, currently we are facing a lot of problem with our social health insurance because we have shifted from the more restricted one to include more people, and you see we are having a problem with collecting fund from people from the informal sector, which is increasing administrative cost. And as a result, private health providers are boycotting the social health insurance. They are saying, first, the packages are unreasonable, the government is not reimbursing in time, and so on. But earlier on, the government was the one accusing them of price gouging, over medicalization, SID, that is supply-induced demand, and so on. And they could bring practical examples where this is happening. Now, how do we marry this so that we can have a partnership that works for everybody, particularly for the people who need the healthcare? Thank you.
So we'll allow them to take this round, and then we'll have another round of questions. So please, if you can start, Dr. Olane.
Thank you so much for the questions. So before I attempt to answer, the NHIA technical lead to the DGs here, so you can assist me. All right. So the structure of the National Health Insurance Authority in Nigeria is such that we have the National Authority, who, according to the NHIA Act of 2022, is the promoter, integrator, and regulator for all health insurance schemes. Now, we also have state health insurance agencies, and we have 36 states. So there are 36 of them. Okay, you asked the question. And then even the Federal Capital Territory has its own health insurance scheme. So we have 37 pools, and then the NHIA, not to count the private health sector of the private health insurance organizations. So this is a challenge, we know. It has its own advantage of, and that was the plan behind, the decentralization of health insurance in Nigeria, so that the state can reach out more to the people in the grassroots, in their localities, and take ownership and be responsible. It has its own challenges as well. This fact that we have multiple pools, it could be a challenge for viability of those schemes, and then, the risk pool and all of that. So that is your first question about the structure. And then the package, we have different packages. At the national level, we have the formal sector, which are the federal civil servants. And this also answers your question about contributions. So they contribute a percentage of their salaries, goes into the health insurance, scheme as their own contribution. We also have a private sector, scheme that's also that people in the private sector can also go to NHI and also say they want their employees to be on health insurance. Then we have a strategy, an intervention initiative that the NHI developed for the informal sector or individuals, it's called gift ship. That is individuals, families, groups can also come in and buy health insurance. Okay, and then we have the vulnerable groups. Okay, initially we had the Basic Healthcare Provision Fund that was in the National Health Act of 2014. We did not start implementing until about 2019, 2020. And that also catalyzes the growth of the state health insurance agencies, but they were also supposed to receive money from the NHIA and then implement in their states as well. So the BACPF is the #1 source for the vulnerable group fund. So BACPF came first, we're implementing that, and then the NHIA Act, the National Health Insurance Authority Act, came in 2022 that now made the NHIA an authority and then introduced the vulnerable group fund. Because now health insurance is mandatory based on that same law. And so the vulnerable group fund is now sourced primarily by the basic healthcare provision fund, then with all other sources as listed in the law, and then innovative ways that the NHI can also apply. There's also budgetary allocation that the NHI got last year for the vulnerable group fund, but the BACPF itself is part of the vulnerable group fund. And those are the ways that we get contributions to the NHI. Then the question as to who select the vulnerable people, like you said, it's challenging. Originally, so Nigeria has a social register, that the World Bank helped to develop, which is supposed to be like the register for the less privileged. It has a very good systematic way of identifying the vulnerables, right from at every state. They're supposed to do their own, start with geographical targeting, LJ targeting, they go to community targeting, and those registers exist in different states. However, by the time the Basic Care Provision Fund was about to be implemented, it's also for the vulnerable, like we said, some of those registers were not complete in many states because it was a long process. I know that I did visit a state where they told us then that only 7 LJs had been covered, and so the list was not complete, and they had to enroll based on NHIs and directives and funding across all the LJs. But with time, registers have become more credible. But a lot of states still want to do their own community targeting. So there's no one way of identifying them. So social register is one way. And the advantage of the social register is that it can actually, be validated, but states can also do their own community targeting to identify the vulnerables based on community, groups saying these people are vulnerable. We know them, and they write their names, and that goes on up the chain. And then they become the vulnerable that are being placed or benefiting from the BACPF, and then by extension, the Vulnerable Group Fund. There are a lot of funding. Somebody asked about, yes, my sister asked about the out-of-pocket expenditure in Nigeria. So our coverage, is really low, right now. We are just 240 million people. So our insurance coverage of about 9% means that only about 20 million of us or less are being covered by health insurance. So you could see why we have high out-of-pocket payments. And I've mentioned the different ways people can get enrolled. So we don't have tax, direct tax, earmarking, which is one of the innovative ways that was mentioned in the presentation that we have in Ghana. We know that for most countries to achieve universal health coverage, public funding is still the most sustainable way to achieve universal health coverage. And Nigeria needs to start looking in that direction, including earmarks from the revenues that the government gets from different sources. Thank you.
Okay, thank you very much. I think that's really a good question. We've seen that the mistrust between public and private sector happens when there's poor regulation or no meaningful engagement. And by this, I mean, if the government, who is really the steward of and also responsible for regulating the private sector, when there's a weak regulation, most times, like you said, there's the private sector tends to have like sharp practices. Either they overbill or they have like supply-induced demand, like you said. But what we've seen work is more recently there's been a meaningful or like a dedicated framework on how to engage the private sector, and also the need for capacity building of the different health insurance, both at the insurance agencies or authorities, as the case may be, at the national but also the subnational level to engage the private sector. But we've seen that where also there's an association of the private sector, and they engage the private sector through the association and through their members, where they hold like dedicated clear code of conduct, or they're able to advocate within themselves to be responsible, or also support the delivery of quality healthcare services. We've seen that quality healthcare services has really improved in those areas. And there's a lot of empowerment, engagement or involvement of the private sector within the health insurance scheme. So I think it's still a journey. Kenya is not a unique case across the countries where we've sampled. Nigeria, also in Ghana and other countries, this situation exists. But where it's the systems are more strengthened, the regulation is more strengthened, and the engagement is less of a they don't have like more punitive measures, or there's like a fostered collaboration. There seems to be, like improved trust and accountability between both the public and the private. So thank you. I hope that's...
Thank you very much. We'll go for the last round of questions. I think there was a question at the back. Yeah.
Thank you to the presenter. Working. Oh. Okay. Thank you to the presenters. A few issues. I need more clarification on a few issues. One is earmarking money for health. I'm wondering if you've gotten some literature on this. There's a lot of examples that have failed, and I'm still looking for those best practices for countries that have actually earmarked money and it went to health, because money will come, it will go to the big basket, and there will be better priorities than health. So are you, in your research, have you come across that literature that has brought up the best practices in any country? I would love to get to it. It's because it's one of those things that I also love I want to talk about. The other one is a comment. I wanted to comment to the fact that informal sector is hard to mobilize, but it's not impossible. Ethiopia and Rwanda are not the best examples, but at least they offer some examples that we can work with in trying to enroll people in the informal sector. So they are hard, but we always make it like they're impossible when actually countries have tried to enroll people in the informal sector into health insurance. Now, the last one is also to the Kenya, Nigeria example, private sector. I also would like to know if there's literature that you have come across in terms of, so we know that private sector is involved in service provision. Are there examples where private sector is contributing to the financing in any way of these health insurance schemes? If you have that, please share that with me. Otherwise, great presentations. Thank you so much.
Thank you very much. Okay, DG. with your DG hat.
You see the DG this evening, I'm sure. All right, thank you very much for the presentation. So my question is to Yakubu. I struggled a bit with locating what you were assessing in terms of private. My name is Chima Onoka. Locating what you were assessing in terms of private sector in health financing, UHC. Now, it seems to have, you seem to have focused on provision, those that are providers. But there's also a whole chain, private sector involvement in policy shaping for UHC. There's private sector in terms of engagement and resource mobilization, or mobilization of the people themselves in terms of enrollment. Is a private sector involvement in terms of pooling arrangements? Because in some of the countries you mentioned, some are involved in insurance, providing insurance. Are they involved in strategic purchasing? Are there roles that are related to that lessons can be drawn from before the part of provision? And then what of the aspects of, accountability and, that kind of voice aspect? I think it would be helpful in providing guidance about what's going on, to think about it even in a deeper sense, beyond provision. Thank you.
All right, thank you for your question. So it's true that when the legal framework does not specify that earmarks should be directed towards health, they can get lost in transit. So a lot of people in the health sector in Nigeria fought for pro-health taxes. They used to call them sin taxes on alcohol, on tobacco, on sugar sweetened beverages. And those taxes are being collected. But they're in the general purse, the general basket in the Ministry of Finance. And so there has to be a legal framework to earmark and direct those resources to come to the health sector. And in this instance, we're advocating for it to come to the NHIA for the Vulnerable Group Fund. You know, health taxes are not, earmarks are not very much liked by the Ministry of Finance, but they don't like the rigidity. It takes away their flexibility. But then when you have soft earmarks that is like on budget and not off budget, it actually helps them to be more accommodating of earmarks. Now, to give examples, in Ghana, you know, just like someone said here, the National Health Insurance Agency thrives on tax from public funds, you know, and it's the amount paid by individuals is so small that it was easy to achieve coverage. So Ghana is a good example of a country that uses earmarks from public funding and it's working. I know South Africa also uses tax from alcohol, you know, consumption. I have examples of countries. We have, I think, Indonesia also has taxes that they use to fund their health sector. So what I think is the most critical thing is to have a legal framework that, you know, guides the use of such resources. Basic healthcare provision for this good example in Nigeria. 20 years ago, wouldn't have thought would have money that goes directly to facilities, both on the supply side and the demand side. And it's actually changing lives. We've seen one, especially when you make it efficient and effective. So BSCP is a kind of earmark in Nigeria, actually. It's from the budget, but it's earmarked to go to you know, the MPAC, the National Primary Care Development Agency, and the NHIA for health insurance coverage and for direct facility financing. And it comes there unfailingly every year. So that's an example of a system that is working, even in Nigeria as a country.
Yeah, maybe could add on that. I think for several years, we have had a drug revolving fund, and that has been functioning as earmarked by the general budget support, and it comes. I think the biggest problem is which position do we put the Minister of Finance in the Minister of Health? Because we go there only with problems. Every time you don't have money, you just knock the door, but we are not closer friends. So we need to keep a very close relationship with the Minister of Finance, give them, I serve in the board of director for the National Health Insurance Fund in Tanzania. So the deputy, the chairman of the board, we have given that to the payer general. Like the payer master of Tanzania is the one who is the deputy. So she has to pay us. Every check, she's the one who writes the check. So she'll make sure that if you have any demand, she pays. But they don't pay without evidence. That's another issue. How do we get the money? We need also to provide evidence. Instead of, because now we have like 40 billion earmarked for the UHI in Tanzania. It's sitting in the escrow account at the Bank of Tanzania, but cannot come to the health sector because we need to set up the systems and then ask for that money. The last year money went back to the budget because they said, you didn't take it, now we are taking. So I think also, how faster do we pass our regulations? How do we put the framework, as she said, to be sure to get those funding? And if they don't come, then you can put it as a debt. And then you go to the Minister of Finance, like, you know, I still owe you some money. Can you give me? So you keep that dialogue, and there is high level meetings where like the permanent secretary now meet with the president. I know Minister of Health, sometimes they don't want that because that looks like, at least when you have before the president, you present that. And then the chief secretary, I don't know if that is country works like that, there's like a chief secretary who is the top of all permanent secretary, we direct the Minister of Finance, but you need to go and talk to him. So it's also a way of, we cannot keep treating, because one person in the Minister of Finance said, you always come here with the diseases. I give you money, next year you say maternal mortality. So where is money? Why don't you tell maternal mortality is gone and then you have something else? So we go there, tell them about the diseases, And they're like, you're funding diseases. Last time you came with the disease, this time you have the disease. So our problem never ends. So people don't understand them. We need also to learn on how to talk with those means, how to demonstrate our cases. Yeah.
All right, we only have 5 minutes, but I just want to ask a question for Ethiopia. How did you measure perception? How did you measure this? And is this a national measure? Because you're comparing your results to a national measure. How did you measure the perception?
Yeah, I think there's a number of questions to assess the perception of the CBHI membership. That based on the questions that there is adding up the items and to composite variables develop, and after that below the mean and above the mean is, I think, the categorization to measure the perception. I think. Yeah.
So you had a composite.
Yeah.
Okay. All right. It wasn't too clear when you spoke, but now I understand.
Yeah.
All right. So thank you very much. I think there was one last.
Yeah, just one last.
Yeah.
Yeah, just to clarify, and I think they're really good questions. For the purpose of this study, we're looking at private sector engagement in service delivery, but also we recognize that there are more engagement beyond service delivery, particularly looking at the role of the private sector in mobilizing resources. For example, in Nigeria, we have cases where there's a private sector health alliance, which is a focused private sector group mobilizing and supporting resource mobilization, but also advocacy and other area. To cases where there've been meaningful engagement that includes both service delivery and resource mobilization. We've seen the role of the private sector during COVID and some of the experiences that have been drawn from that to help strengthen the healthcare system. In Nigeria, we had a case of COVID, which was a focused private sector entity that helped to improve that and had a very big healthcare component. So as part of our work, it involves other facets beyond service provision, but we're just focused on this study to look at service delivery, but there are other innovative resource mobilization strategies that the private sector is engaged in that we're also looking into as well. And I'm happy to have discussion outside this to clarify further. Yeah.
So thank you very much, everyone. Thank you to our panelists. It's been more than being in a classroom because there's so much we've learned today. If you would agree with me, the presentations have been very rich, and we go away with a lot of insights that we've gained today from hearing all our presenters. So let's keep the discussions going, and let's continue to engage. Let's form new networks and keep pushing the boundaries. We'll never get all the answers right, but at least we'll get closer and closer to the solutions. Thank you very much, everyone. Thank you.
Africa. Like I said, I'm Nyasha Masuka. I'm a specialist public health physician from Zimbabwe. I work for Clinton Health Access Initiative, and I'm a member of AFIA. So we'll just go straight to our presentation since we are a bit late. I don't know, by show of hands, the presenters who are here. Okay, so there are 4 out of 7. So maybe is Adaora here? Then Louis? And Ofiong? No, Patricia? Yes. So one thing is I didn't get the bioblebs from the presenters. No, I'm just following the list of people, so I'll go on. So I think maybe you can present, and this discussion, like the topic says, is advancing vaccine equity and access to primary healthcare services. And we all know the issues that are around our decentralized health systems, where we aim to provide quality primary healthcare services by improving geographical access, financial access, and psychological access to our people. We also know in all our vaccination programs, the issues that have to do with logistics supply chain of those vaccines, and issues around the cold chain, and also issues with populations that live in hard to reach areas. So I think this is the discussion that we are going to have. So maybe we can have the first presentation from Patricia. Maybe you can then do your bio yourself, because I don't have it and it's in French.
OK, merci beaucoup. It's working? Ah, it just only for the. Okay, it's okay. It's okay. OK, bonjour à tous. Moi, c'est Dr Patricia Martin. Je suis de Madagascar et chargée de programme maladies tropicales négligées au sein de l'OMS. Donc, j'ai mon master en santé publique et en médecin aussi. Et avant, j'ai travaillé aussi en tant que équipe technique de la vaccination, surtout équipe d'éradication de poliomyélite dans le pays. Normalement, je prends la place du modérateur pour ma biographie. Donc, maintenant, en tout cas, je vous remercie. Et là, je vais vous présenter notre étude qui concerne l'intégration de deux campagnes à Madagascar et par rapport à une intégration de campagnes de vaccination contre la poliomyélite et la distribution de masse de médicaments contre la filariose lymphatique. Et dedans, c'est pour voir un peu l'impact de tout ça par rapport Voilà. Donc, premièrement, pour vous dire un peu, Madagascar, en fait, c'est une grande île dans l'océan Indien. Et vraiment, c'est une grande île parce que en superficie, on a 587 000 km² avec une population plus de 30 millions. Et nous avons 23 régions et 114 districts. Quand on parle maintenant de la maladie tropicale négligée, donc en tout cas, 39% des fardeaux mondiaux, en tout cas, c'est dans les maladies tropicales négligées. Et quant à Madagascar, parmi les dizaines de maladies tropicales négligées, filariose lymphatique en fait partie. Et 87 districts sont encore endémiques, dont 4 déjà en arrêt de traitement qui ne nécessitent plus de chimioprophylaxie préventive. Et comme nous voyons ici, ça ne marche pas le pointeur en fait. Comme nous voyons ici dans la carte à droite, donc ce qui sont en orange en fait, ce sont des districts qui sont encore épidémiques et en bleu, ce sont des districts encore endémiques mais en arrêt de traitement. Et ce qui sont en vert, ce sont les districts non endémiques. Et nous avons aussi une co-endémicité avec la schistosomiase, géolmenthiase et la téniasis. Et le 69% de la population malgache donc, est encore exposée à cette maladie filariose lymphatique. Donc, mais pour vous dire, on a quand même pu avoir des progressions parce que si en 2018, nous étions encore à 89 districts endémiques, en 2023, nous étions passés à 87 districts, dont 83 qui nécessitent encore le traitement. Et juste pour vous dire, c'est que pour le MDA, c'est ce qu'on appelle l'administration de masse de médicaments. Donc, il faut la couverture thérapeutique de 65% pour avoir l'objectif escompté. Maintenant, pourquoi on a fait cette intégration? C'était quoi le catalyseur dans tout ça? C'est parce qu'on sait que le gouvernement malgache, en fait, il y a déjà le clinique mobile où on fait déjà des intégrations des activités pour le soin de santé primaire et aussi pour les partenaires. L'optimisation de ressources aussi est très intéressant et les partenaires aussi sont convaincus qu'en optimisant les ressources, on peut aller vraiment de loin. Et puis, bien sûr,
pour le coût-efficacité. Et puis, nous avons aussi un engagement fort de la communauté aussi au niveau de Madagascar parce que déjà, on a 2 agents communautaires par chaque village à Madagascar et ça, c'est vraiment dans notre fonctionnement du ministère de la Santé. Alors, par rapport à l'étude, notre méthodologie est que, vous voyez, comme je disais tout à l'heure, on a 83 districts qui nécessitent encore le traitement et donc on s'est focalisé dans le traitement de masse dans ces 83 districts où on avait intégré campagne polio aussi dedans. Et donc, il s'agit d'une étude observationnelle, transversale, et que c'est l'objectif de l'étude, c'est vraiment voir l'impact de cette intégration de campagne par rapport aux résultats que nous allons avoir. Est-ce qu'on va atteindre nos objectifs escomptés par rapport à la couverture thérapeutique et géographique. Mais ceci dit, le MDA, en fait, c'est pour la population totale. Population totale plus de 2 ans. Donc là, on donne le traitement obligatoire. Et nous avons 2 stratégies, la bithérapie et la trithérapie. C'est le DA et IDA. Et nous avons pu mobiliser plus de 30 000 distributeurs communautaires au niveau des villages et dans plus de 15 000 villages dans ces 83 districts. Donc, qu'est-ce qu'on a fait? C'est encore dans la méthodologie, c'est qu'on a comparé, en fait, par rapport à une micro-planification pour avoir le budget nécessaire quand on ne fait pas l'intégration et on a comparé ceci avec le budget qu'on a utilisé une fois qu'on a fait l'intégration. Donc, on s'est focalisé sur ces 5 points, la coordination, la logistique, le déplacement et les indemnités, la communication, ainsi que les différentes formations que nous devons mener quand on mène des campagnes de masse. Donc, voilà un peu le résultat pour vous montrer. Donc, en haut, à droite, c'est par rapport à la distribution de masse de médicaments contre la filariose lymphatique, à droite, et celui de gauche, en fait, pour la carte, c'est par rapport aux résultats qu'on a trouvés par rapport à la vaccination. Donc, en tout cas, en 2023, où on a fait cette intégration, donc seulement 2 de ces districts qu'on a fait l'intégration qui n'ont pas pu avoir les objectifs escomptés, parce qu'en vaccination, il faut qu'on ait plus de 95% de couverture thérapeutique. Et seulement 5% des districts qui n'ont pas pu avoir aussi des résultats sur les 83 pour la distribution de masse de médicaments. Et en 2024, tout ont atteint leurs objectifs escomptés. En tout cas, une chose est sûre, ce que nous pouvons dire, c'est que, vous voyez la courbe là, regardez sur la courbe en rouge. Madagascar n'a jamais pu atteindre la couverture thérapeutique par rapport au district endémique qu'en 2023 où on a fait l'intégration. C'est là où la première fois, depuis une quinzaine d'années, qu'on a pu avoir une couverture géographique de 100% en fait. Et puis, l'intégration aussi avec la mobilisation de tous ces distributeurs communautaires, on a pu aussi recenser des cas d'hydrocèle. Et à Madagascar, donc du coup, ça nous a permis de recenser 14 000 cas d'hydrocèle et 15 000 cas de lymphœdème. Donc, voilà un peu le résultat, vraiment, par rapport le gain financier que nous avons pu avoir. Au lieu que pour la première année en 2023, au lieu d'utiliser 1 398 000 $ pour une activité d'une semaine, on a juste utilisé pour le programme que 340 000 $ grâce à cette intégration. Et donc, ce qui fait qu'en 2 ans d'intégration avec la campagne contre la poliomyélite, nous avons pu avoir un gain financier de 1 230 000 par rapport à cette intégration. Donc ça, c'est vraiment intéressant et c'est pour cela que nous voulons vraiment nous montrer ici lors de notre rencontre. Donc, par rapport à tout ça, en fait, c'est que qu'est-ce qu'on peut tenir en tête? C'est que grâce à l'intégration, donc, on a pu vraiment atteindre la couverture géographique de 100% dans toute la communauté. Et puis, les objectifs thérapeutiques étaient atteints parce qu'on a pu avoir les 16 millions de personnes cibles. Je ne vois pas en fait. Oui, et donc du coup, par rapport à cas d'hydrocèle, l'hydrocèle et l'infodème aussi, cas de morbidité, on les a tous trouvés. Et tout ça par rapport à la coordination, le fait d'avoir une seule coordination au niveau central, au niveau district, ça nous a permis aussi de vraiment avoir tous ces gains financiers. Parce qu'au lieu d'envoyer par exemple un camion pour que la vaccination, on a pu mettre aussi les médicaments et les intrants pour le MDA. Et la communication aussi, c'est la même chose. Donc, au lieu de faire une communication que pour la vaccination polio, où ils ont vraiment le fond avec tous les Gavi, le Bill et Melinda Gates, donc on a pu en bénéficier aussi par rapport à ça. Donc, en conclusion, en fait, c'est que nous pouvons dire que l'intégration, ça nous a montré vraiment l'efficience, l'atteinte des objectifs escomptés pour les deux programmes. On n'a pas déshabillé Paul pour habiller Pierre, mais les deux programmes ont pu avoir les résultats escomptés. Et puis, voilà l'importance aussi de la collaboration parce que avec plusieurs programmes, on a pu aussi se collaborer depuis le niveau opérationnel, au niveau de la communauté, jusqu'au niveau central. Et puis, c'est aussi une innovation. Ça mérite aussi une recherche. C'est ce qu'on voulait aussi montrer. Et puis, on pense que comme on veut vraiment atteindre les objectifs d'ici 2030, c'est d'éliminer les maladies tropicales négligées, dont la filariose lymphatique. Ceci vraiment est un bon exemple qu'on peut répliquer. Sur ce, je vous remercie.
Yeah, thank you very much for that presentation. You were on time. Surprisingly, you used the last 1 minute very effectively, like what you have demonstrated in your study, that you demonstrated high levels of efficiency and coverage with integration. I know we'll discuss in the question and answer session the challenges that almost all of us face when trying to integrate some of these programs. So we'll go on to the next presentation. Oh. So is Janet there? Yeah. So she's going to present on willingness to pay for rabies vaccination services and associated factors among communities in Geita district in Tanzania. Thank you.
Good afternoon, everyone. My name is Janet George Laurian. I work for the Open University of Tanzania. I'm a lecturer and researcher in One Health Economics and Health System Research, but more passionate about systems thinking. And I would like to share with you the 2 cents about the willingness to pay for rabies vaccination services and associated factors among communities in one of the districts in Tanzania. And what drove us to do this research was to look on the demand side, what was the collective action that people are willing to take in addressing some of the neglected diseases. So rabies is a viral disease that affects the nervous system, and in Tanzania is among the major public health threat and mostly underreported. And Currently, it costs about more than 1,500 deaths annually. And vaccination is one of the cost-effective methods that have been reported. In Tanzania, currently, rabies vaccination, because this is a public health issue, is mandatory. But according to the law and regulation, is treated as a private good that people have to pay for them to access this service. And in Geita, rabies cases are on increase. So we wanted to understand to what extent people are willing to take action and, so to speak, paying for this service, and why are we having raise on these cases. So this was a bigger study, but we chopped the willingness to pay as one of the economic components. The methodology that we used, we did a cross-sectional study, and we went for both owners and non-owners of dogs, because at one point, someone may own a dog today and then disown it. So you find it's kind of a circular practice. So we did a three-stage sampling where Geita was selected purposively due to the increased number of cases. And then we selected wards where they had high cases of rabies and where they had relatively low cases of rabies. And then we did a proportional sampling and random sampling to select participants in the communities. And for the data analysis, data collection, we use the bidding technique, which is one of the willingness to pay techniques for dog vaccination and post-exposure prophylaxis. And then we did the descriptive and logistic and regression for analysis. And this is how the bidding techniques work, where you have the initial bid. In this case, we took the prevailing price, which was 300,000 Tanzanian shillings, equivalent to $1.2. And then from there, if someone says, you ask the question if that person is willing to pay for that that amount. If he or she says yes, we keep on increasing the amount. And if he or she says no, we keep on decreasing the amount until we reach a point that I can't go beyond this, or I can't go below this amount. So we did that for dog vaccine and the human post-exposure prophylaxis, which was about $20. And then these are some of the results. We managed to collect data from 312 respondents, where almost 30% were female, and 62% were willing to pay more than prevailing price, which was a very good thing. And 26% were willing to pay less than prevailing price. But there was a group of people, 4%, who didn't want to pay anything because they believe this is a public health issue. So it should, the vaccination should be free, both for PEP, but also for dog vaccination. So on average, people are willing to pay around $1.5, but there are some who are willing to pay up to $12. And some of the reasons that the argument that people were putting forward was that, why should I vaccinate dog? Why the price of vaccination for dog is higher than the price of vaccinating a food animal, yet you don't eat dog. So these were some of the arguments that they put forward, that they think dogs, vaccination costs shouldn't be higher than for food animal. And some of them, we try to associate factors but depending on different demographic parameters. And we learned that people who had higher education were willing to pay the highest. This may be associated with the understanding of the disease itself and the risk it imposed. And then the primary and secondary schools also were relatively willing to pay higher, but those who had no formal education were willing to pay the lowest. In terms of gender, men were willing to pay more, almost $2, while female were willing to pay relatively late. I had an explanation for that because when you compare the income level between men and women, you get men has relatively higher income, which may explain why they are willing to pay more. But also we try to look the association between risk factors and their willingness to pay. And we learned that people who have ever bitten by dog have ever bitten by dog were willing to pay less, while those who has never been bitten by dog were willing to pay more. And we had the explanation for that, I was ever bitten by dog, but nothing happened. So I don't feel that it's a risky to be bitten by dog. So if I've never encountered a dog bite, I feel I feel it's riskier, or the chance of contracting rabies is high. But those who also have ever heard about rabies, they have understanding of rabies, they are willing to pay high compared to those who have never heard of rabies. But the figure kept increasing for someone who has ever seen a rabid dog. The expression that they are giving is so frightening to see a rabid dog. So they are willing to pay higher to vaccinate their dogs so that they don't encounter this kind of scenario. But the most of all is that people who have ever encountered a rabid person with rabies were willing to pay the highest. There were very few cases, but they were very traumatized to see it, or to see a person with rabies. So in that case, people are willing to, the level of risk depends on, have influence on how much people are willing to pay. In terms of post-exposure prophylaxis, people are willing to pay up to $20 on average. And again, men are willing to pay more for the same reason that I've explained. But the interesting part is that people who have ever heard of rabies are willing also to pay more, while those who haven't are willing to pay the least. It's not even on the threshold. And those who have ever seen a rabid dog were willing to pay 32% higher than anyone who has ever seen a rabid dog. So, some of the quotes that they were giving us that human life cannot be traded for anything. So they are ready to pay for whatever it takes to save life. So to conclude, we learned that participants were willing to pay more for post-exposure prophylaxis as compared to dog vaccine. And there's association between education level, risk of perception, and gender, and regard to willingness to pay. And lastly, based on the parameters that we saw and analyzed, we feel there's a need for more awareness campaign because of the level of risk that people perceive. The higher the risk perception, the higher the willingness to pay. So our hopes is that the more we give awareness about the disease, the more we'll have more people aboard and taking collective action. In this case is vaccinating against rabies. So thank you very much. And these are some of my partners that have contributed to this work.
Thank you very much, Janet. That's a very interesting study where I think doing qualitative studies gives you more information on what interventions to put in place for uptake of healthcare services. We'll go on, is Wilson, yeah? Yes, we'll go to Wilson Onyilimba, who is going to present on Ward Development Committee, a catalyst for strengthening primary healthcare management, and is presenting evidence from Yobe State in Nigeria.
Good day, everybody. My name is Wilson Onyilimba, and I work with HSCL Health Systems Consult Limited, and I'm here to present the Ward Development Committee a catalyst for strengthening primary health care management. An insight from Yobe State, a northeastern state in Nigeria. Okay, just a background. We know that Nigeria, they face challenges in inadequate funding, financing, data management for healthcare. And Yobe State, a northeastern state in Nigeria, they've had issues around insecurity, and that has also contributed to the limited funding and financing that comes for primary health care. So the government of Nigeria, they understood that, and then they decided to introduce the the World Development Committee as a strategy to help curb that challenge and improve both financing, planning for PHCs. And this World Development Committee, they are a local level committee that operates within the community. They are part of the World Health Systems Framework. So what they do is they help facilitate the mobilization and governance of community resources and financing. So the members of this committee, they are people from the local government, they are health workers, they are people like traditional rulers, religious rulers, and people like that. They are the people in this committee, and then they have a responsibility to collaborate with the PHC facilities, and then they plan for the social and health needs of the community. They also have like a co-signatory kind of relationship with the facility where the chairperson is co-signatory to the finances that come to the primary healthcare facility. So that helps with financial management. And then they also help boost community participation within the facility. So they are like an important link from the community to the health facility. And the objective of the study was to assess the role the WDC play in tracking management of PHC financing for improved service delivery. And so for our method, what we did is we conducted a mixed study where we purposefully sampled 20 facilities across 3 senatorial districts in Yobe State, just to ensure spread and that we have a good representation of areas, different areas within the state. And then what we did, we had like KIIs with the health facility officers in charge. We had with the WDC chairperson, because they are co-signatory to the accounts of the primary healthcare facility. We also reviewed their reports, their financial reports, their stock reports. We also did some data abstraction just to know the level of completeness of their books. And then for analysis, we use the quantitative and descriptive analysis just to identify the effectiveness of integrating the WDC into the PHC management structure. So after that, this here is just a snapshot of what we found. So we found that the 20 facilities we assessed as a result of the integration with the WDC, the World Development Committee, they had up-to-date financial records. They had attended review meetings with the facilities, and then their accounts were reconciled with the banks. This was 3 months prior to our study. And then we also found that there were no stockouts of essential medicines in the facility, vaccines and things like that, because as part of their responsibility, they are also supposed to help the facility plan for their medicines, for their business plan and the things that they do. And then we also saw that because there are things like ad hoc staff. So these staff, they are employed by the PHC, and then the WDC chairperson, along with the officer in charge of the facility, they are in charge of payment of this staff. So we saw that 80% of the facilities that we assessed, there were no late payments. There were early releases of funds. I mean, the other 20%, they eventually paid, but it just took some time. And then we found that just in one facility, that there was operational efficiencies because there was like a disconnect between the officer in charge of the facility and the WDC chairperson. So that's really tied down release of funds and other essential medicines and things like that that came to the facility. So to conclude, this study shows the effectiveness of the Board Development Committee in PHC financing and facility management, resulting in improved quality of service delivery, health outcomes in UV. However, there is a need to support this committee as policymakers, health administrators. They need to support them, sensitize them, so they know their role and they are really up to the task when it comes to service delivery and improving access and managing the primary healthcare facility. Thank you, everybody.
Thank you very much, Wilson, for that. I mean, you did it in record time. You still had 2-3 minutes to finish. So I think this is a very important presentation as well. And it's something that we'll discuss in the panel, the issues of ownership by local communities in utilization of their resources for social services and making each other accountable. Thank you. So now we'll have Said Aiden Mohammed, who is going to present on decomposing socioeconomic inequality in zero-dose vaccination status among children in Somalia. He's presenting evidence from Somalia Health and Demographic Survey done in 2020.
And my name is Saeed Mahmoud. I'm a research advisor for the Save the Children Somali Country Office. And I would like to present a socioeconomic inequality of zero-dose vaccination children and among the 12 to 23 months of children in Somalia, using the first and the only DHS survey in Somalia. And vaccination, as you're all aware of, it is one of the most effective public health intervention, as it has saved millions of children and from death. But still, there is a challenge of vaccine preventable diseases, which still remain a problem, and there's outbreaks of vaccine preventable diseases due to the existence of pockets of zero-dose children and under immunized communities across the world. In Somalia, it's considered one of the countries that have traditionally low vaccination coverage. And the most recent survey shows that around 10% of children are fully vaccinated against all the 4 basic vaccinations, all the 4 basic vaccine antigens. And as a result of that, there is a frequent outbreaks of measles, diphtheria, and some other vaccine preventable diseases. In this study, we would like to investigate, and there is also Somalia is one of the countries which has the largest zero-dose vaccination children. And what we would like to observe and investigate in this study is the socioeconomic inequality of zero-dose children among in Somalia. The methodology, the approach that we use, this study, we use the first and the only Somali Health Demographic Survey, which was conducted in the year of 2020. We have tried to extract all the variables that are interested with the focus of children that are aged in 12 to 23 months, because this is an age that's recommended for the immunization and indicators. We excluded, while we are doing this data extraction, diseased children who are below 12 months or above 23 months, and those children who have a missing data for some of the variables that we are interested. The outcome of our study for the zero-dose vaccination children we considered and used the operational definition of considered children as SERA dose when they did not receive any DTB1 dose. And for the analysis of equity, we have tried first to look how the SERA dose children are distributed across different socioeconomic variables. And we also look beyond that, and we have used socioeconomic, some of the parameters that's used for inequality, which is concentration index and concentration curves, so that we will look how the socioeconomic or SERA dose children are distributed across the different wealthy quantiles. And what we have found is that we extracted and used the study criteria, and we found around, and the sample that we will use for, we use it for our study is around 2,188 children, which are aged 12 to 23 months. And our study found that the SERA dose children who did not receive any DTB, is very high. Around 77.4% of the children did not receive the first and DTB1, which is saying that this is very alarming, and which means it's very high. We have also tried to look how these children are distributed across different variables, socioeconomic variables, healthy service utilization and variables, as well as some of the other parameters. And what we have taken some of the variables which shown that there is a great distribution and there is inequality of the SERA dose children. And what we found is that majority of children who did not receive the first DTB1, which is SERA dose children, are born by mothers who did not attend any schools. 86% of these mothers who have SERA dose children did not attend any school. Those that have limited exposure of media. We have tried to combine several indicators of media, listening of radio, watching TV, as well as reading newspapers, and we merged it together, and we found that most of the children, around 97% of the children of the mothers who have SERA dose children, then did have limited exposure to media. We have also tried to explore how the empowerment of the mothers have impacted or distributed the SERA dose. And what we found is that we have tried also to look using some of variables that are found in the survey, and we come up with into a category of fully, partially, and not partially. And what we found is that mothers who have SERA dose children, is around 71% of them have little or no empowerment at all for their decision making. We have also tried to look how the SERA dose children are distributed across the distance of the mothers will travel to attend or seek care, as well as the service delivery utilization is like ANC or delivery. And what we found is that around 2/3 of the SERA dose children were born by mothers who reported that they face challenge when they want to access health facilities because of the distance. And what we have also explored, we have also found that mothers, children who have SERA dose were also born by mothers who did not attend antenatal care. And this is an opportunity where the healthcare workers could provide a counseling about the importance of having children vaccinated. And we found that 81% of them did not attend health facilities. And around 85% of them, mothers who had SERA dose children, give birth their children is at home. We have also tried to look how the SERA dose children are distributed across different residences and as well as the wealth quintile. And what we have found is that SERA dose children are distributed in areas that are remote areas that are very difficult to reach. It's found that most of the SERA dose children are from the remote areas, the rural and the nomadic populations. We have also found that the SERA dose children are also concentrated in the lowest and the second lowest quintile, where there is around 21 or 25 of the children are from the lowest quintile, and there is less in the highest quintile or the richest quintiles. We have also tried to look not only the distribution across these variables, but also tried to look some of the measures that is used to measure socioeconomic, and inequality, which one of them is the socioeconomic concentration. Socioeconomic concentration is one of the parameters that's used for inequality, and it's usually used to plot the cumulative and percentage of those children against the cumulative percentage of the population is ranked based on the wealth index. And usually there is a curve which is called 45 line or equality line. If you draw that line, the line of the curve that will come up after you draw it could be in three places. It could be on the around the 45 line. It could also go above, or it could go below. And if it's around the equality line, it shows that there is no inequality, that it's equally distributed across the different wealth quantiles. But if it's go above, it shows that those children are distributed in the lowest quantile. And if it's below the equality line of 45, it shows that the those children are distributed disproportionately in the highest quantile. And as our study is mentioning, is that it shows that the line of the curve that we get when we draw the concentration curve, it's above the equality line. And that means that the those children are disproportionately distributed in the lowest quantile. We have also tried to do concentration index. Concentration index is also a parameter which shows the relationship and the strength between the those children and the wealthy quantile. And the number can be in between, and it could be zero, below zero, or above zero. If that number is zero, it means there is no inequality, and the those children are distributed in the different quantiles, wealth quantiles. If it is minus or below zero, it means that those children are distributed in the lowest quantile, and the other is first. And as you can see, the index that we get it's minus 0.2. It's aligned with the findings that we get with the concentration index, concentration curve, and shows that this is significant. In conclusion, our study found that the those children is high prevalent in Somalia, and is predominantly born by mothers who did not attend school, under-empowered, not access, which has a limited access to media, as well as has a limited access to maternal health services. And it's also concentrated in remote areas, including the rural areas and the nomadic populations and the low socioeconomic populations. So the study recommended to have a multifaceted broad interventions with specific targets of improving the maternal education, empowerment of the mother's decision-making, improvement of the access and the utilization of maternal care, as well as increasing the access and the availability of the vaccinations in remote areas, including the nomadic populations, are also providing socioeconomic supports to most vulnerable populations. Thank you so much. Yeah.
Thank you very much for that. Very interesting findings there. I think it will be also interesting to unpack some of the findings during the panel discussion. So maybe the presenters, you can come to the front, and we can have questions, clarifications, or any other issues from the rest of the group. So can I have questions? Any questions, clarifications?
Hello, good evening. My name is Nateia. I'm a medical doctor by background, but I'm venturing into global health.
May you please speak up?
I'm venturing into global health research and health economics as a PhD student at LCM. My question or comment is to Janet. I am a Tanzanian, so I've been working at KCMC Hospital for a while. And we have seen a lot of rabies cases. And one of the challenges is getting the vaccine, the PEP, on time. I don't know what you have as a comment to that, and if you're planning on doing further research on availability and access from the providers of these PEP vaccines?
Thank you. We'll take a few more questions if there are any before we get responses. Okay, maybe we can have a response from her.
Thank you very much, Nat. And regarding PEP, this was also a hardship that we found in the field. And the arrangement that they have actually complicates everything. That the person who pays for PEP is the owner of the dog. So if your dog bites someone and is not vaccinated, that means you have to pay for the service. So what happens is people don't go for PEP most of the time. And the worst case scenario that we found is that they are forging the cards, the vaccination cards for the dog. So when your dog, someone's dog bites a person, that person shows that my dog is vaccinated, but in reality, that dog is not vaccinated. So there were cases of someone died out because of that, but also availability of PEP itself. They are mostly on the secondary facilities, not primary facilities. So someone has to travel a distance. Normally it's 50, they charge you 50 equivalent to $20, but the costs, the indirect cost associated with accessing the vaccine itself is super expensive. So it goes up to $100 from 20, which is the actual cost of vaccine. So the situation is not appealing as we speak. And that's why we wanted to feel also to learn from the demand side, how much people are willing to pay so that we can have this conversation on how the supply chain, but also how people can also contribute to the collective action. Thank you.
Thank you very much for that response. I think the rabies vaccine issue is a big issue in many countries. In my country, it's the same as well, where the dog owner is supposed to pay for the vaccine. While they are supposed to do that, finding the vaccine is a problem, and you find it in the private sector. And people struggle a lot to pay for that in time for it to be effective. So it's a common issue, and I don't know if it's an issue of prioritization in terms of our essential medicines and vaccines, where you can see the difference between what has been happening with our vaccines that are funded by donors and our vaccines that we should fund ourselves. So I think that's where one of the issues remains an issue to say, how do we then make sure we mobilize resources locally and make sure that, especially where this is such a huge burden, like in your case, right? I would like to ask Patricia. So, and the other panelists as well, and anybody in the crowd can come in afterwards. We know for the longest of times, especially since the advent of vertical disease programs, HIV, TB, malaria, and so forth, and the structure in which that has been done, that there's a lot of influence by national program managers of those programs to keep them vertical in order to ring fence resources. And there are usually serious turf wars that cascade down to facility level or to district level because there are different people who are in charge, even if there's a district medical officer or even if there's a regional medical director, but there are people through which those programs flow. So I would like to understand what were the success factors that made this work in this case? Was it because I mean, in fact, you can elaborate on that.
C'est bon si je réponds encore en français? Ok, merci beaucoup. Donc, en tout cas, par rapport à ça, effectivement, hein, la verticalisation des programmes, c'est vraiment un problème. Je pense que c'est partout. Et effectivement, nous, comme j'ai présenté tout à l'heure, le catalyseur, c'est que vraiment, on a déjà des cliniques mobiles dans le pays. On fait même ce qu'on appelle, comment on appelle ça? Oh là là. On regroupe tous les techniciens, les médecins et tout ça, et on fait des descentes vraiment sur axe dans tout Madagascar. Donc, ça nous a déjà donné une idée que pourquoi pas faire aussi une intégration par rapport à la lutte contre la maladie tropicale négligée, étant donné que c'est un gros problème de santé publique, mais qui n'est pas du tout de fonds appropriés pour ça. Donc, effectivement, c'était difficile de convaincre au début, vraiment difficile, même pour le partenaire. Comme vous avez dit, la verticalisation, si moi j'ai de l'argent, je ne peux pas donner ça parce que j'ai toujours peur que mon résultat ne va pas sortir parce que vous allez utiliser mon argent. Mais avec plusieurs discussions, vraiment, on a pu quand même engager le ministère de la Santé à accepter cette intégration parce qu'on s'est dit que, bon, voilà, nous, en tout cas, au niveau de l'OMS, on a vraiment l'idée à ce qu'il y ait cette intégration avec plusieurs approches vis-à-vis de tous les partenaires et le ministère. Et donc, une fois que c'est intégré, donc, qu'est-ce qu'on avait fait? On a fait une planification quartier général en appelant tout le monde à faire des réunions sur table pour toutes les préparations. Discuter vraiment parce que, en fait, on a constaté que c'est parce qu'ils ne savent pas aussi le problème autour de cette maladie filariose lymphatique. Parce que la morbidité, certes, c'est moustique malaria, c'est demain, au bout d'une semaine, on a déjà le palu. Tandis qu'avec la filariose lymphatique, c'est au bout de 10-15 ans qu'on trouve l'impact, la morbidité, que ce soit en lymphœdème ou hydrocèle. Donc, on néglige complètement comme son nom l'indique. Donc, vraiment, le fait, après, une fois que c'est accepté et avoir le quartier général où tout le monde dans le quartier général avait compris ce que c'est que le fardeau engendré par cette maladie, ça nous a permis d'aller de l'avant. Maintenant, on a regroupé par thématique maintenant à chercher à anticiper même les problèmes, quels sont les problèmes qu'il peut y avoir et déjà anticiper aussi les solutions parce qu'effectivement, c'est un problème. Si moi, au niveau de communauté ou centre de santé de base qui fait la distribution communautaire ou la vaccination, avoir 2 campagnes, je peux avoir 2 indemnités différentes. Tandis que là, on combine tout. Donc, c'est tout un problème, mais on a pu quand même aller de l'avant par rapport à ça. Donc, je ne sais pas si j'ai pu répondre à votre question, mais vraiment, le success story, c'est vraiment la coordination, la bonne coordination, le fait d'expliquer le fardeau engendré par la maladie. Et après, bon, voilà, c'est démontrer que c'est faisable parce que pourquoi on fait des caravanes médicales avec plusieurs médecins pour traiter les gens et que les gens viennent et pourquoi pas aussi intégrer ces fonds-là pour pouvoir aussi gagner les résultats. En tout cas, pour ceux qui sont intéressés aussi, c'est une étude publiée dans le, comment on appelle ça là, pour le NTD, le site web de NTD. Donc, vous pouvez voir sous le nom, vous tapez même filariose lymphatique Madagascar, donc vous pouvez directement le voir. Et avec aussi notre représentant, professeur Laurent Moussango aussi, qui nous a appuyé sur toute analyse sur l'économie financière. Merci.
Yeah, thank you very much for that response. I don't know if any of the panelists also you want to chime in, if you know any issues about integration. Do you think this is going to happen for HIV after, and how do you think it will pan out?
Peut-être aussi que ce que je peux aussi rajouter, c'est que effectivement, il y a l'intégration, mais il faut aussi juste analyser quelles sont les activités qui sont intégrables. Ce n'est pas juste aller, bon voilà, je vais intégrer ça, mais c'est vraiment analyser quelles sont les activités qui sont intégrables. Par exemple, une fois, on m'a posé la question, pourquoi vous avez intégré avec la vaccination alors que la vaccination, c'est pour les enfants de moins de 5 ans? Et la filariose lymphatique, c'est pour la population totale, jusqu'à personnes âgées. Et donc, en fait, pourquoi? C'est parce que les cibles, enfin, la stratégie, c'est porte à porte. Donc, on a la même activité. On toque les portes, on donne le vaccin contre la polio parce que c'est des gouttes à la bouche en mobilisant les agents communautaires. Et pareil pour les médicaments, on mobilise aussi des distributeurs communautaires et ils toquent la porte. Et une des choses aussi que j'aimerais bien aussi partager, c'est que pour éviter les effets indésirables, parce qu'on n'a pas encore assez d'études par rapport aux effets indésirables à la, en combinant le traitement. Donc, qu'est-ce qu'on a fait? Et pour ne pas aussi entraver la vaccination contre la poliomyélite, c'est qu'on a envoyé d'abord le premier jour les agents communautaires pour donner la vaccination contre la poliomyélite. Et c'est le lendemain que les distributeurs communautaires viennent maintenant et toquer les portes des villages qui ont déjà effectué la vaccination. Comme ça, on ne va pas dire que c'est à cause de médicaments ou à cause du vaccin, l'effet indésirable qui va apparaître. Mais en tout cas, on n'a pas pu avoir, ça aussi c'est à partager, on n'a pas eu des effets indésirables lors de notre intégration. En tout cas, je dirais, les MAPI graves, il n'y en avait pas. Et non plus les effets indésirables dus aux médicaments aussi graves, nous n'avons pas eu aussi. Merci.
Thank you. I would also like to comment on that about whether integration of these vaccination campaigns will bring some, I think with what is happening now with geopolitics, we have to go back to the drawing board, and that's the role resonate with our theme, that's the role of health economics. How many countries have health economists in-house in their ministries telling, because I think for them, they may not doing this kind of research, but they may understand the language that we tell them. For instance, the demand side shows that people actually, they are willing to pay, but the supply chain is what disappoints them. So how do we bridge these gaps? And how do we inform with evidence that I think you can take this amount and put it here and this will be the outcome? So I think we need to go back to the drawing board. And for me, I think integration is the only way out to get out of this. In Tanzania, we have rabies is among the priorities on tick diseases. We have strategy for rabies elimination, but when you go to the ground, you don't find PEP, you don't find dog vaccine. So what's the point of having all these documents if you don't have resources? So I think we need to push further for integration to be able to take all these diseases together. Thank you.
Yeah, I think that's very important. I was in another session yesterday where a presentation from WHO and others also showed that we are doing ritualistic things like developing essential benefit packages for primary care, for secondary care, for whatever. But when you go there with hypertension, the medicine is not there, but it's written in some document that this is part of the benefits that you will get. So I think it's very important that, we be realistic using evidence and data, these economic evaluations, and saying health financing should inform how you design your benefit packages instead of being aspirational and creating expectations, and then those things don't work. Right. So I was going to ask you, you want to say something?
No, just asking a question for my, I don't know. Okay.
Okay.
Just
Yeah, you can.
Yeah, okay. Donc, moi, je voulais poser une question par rapport à... non, je crois que c'est notre ami ici, là, par rapport aux zéro doses dans leur pays. It's okay? Donc, vous avez dit que vraiment, les 65,6% ont un problème d'accès aux formations sanitaires. et que vous avez 77,4% de zéro dose dans votre pays. Et que, bon, voilà, c'est parce que, bon, voilà, il y a un problème d'éducation pour les mamans, les limites avec médias, et puis, bon, voilà, tout ça. Donc, moi, ma question, c'est que, et vous avez dit aussi que comment ces zéro doses sont concentrés dans les maisons avec niveau social pauvre. Donc, vraiment les zones urbaines, avez-vous vraiment mené aussi la même enquête et que vous avez vraiment trouvé que même dans la ville, il n'y a pas de zéro dose? Parce que dans d'autres pays comme les nôtres, par exemple, les zéro doses se concentrent beaucoup plus en fait en ville. Parce que c'est là où les gens disent oui, on est vraiment éduqués et on ne veut pas votre vaccin. Donc, je ne sais pas, est-ce que ce n'est pas votre cas dans votre pays? Et aussi, est-ce que vous avez aussi d'autres stratégies pour atteindre ces enfants des zéro doses? Parce que vraiment, c'est énorme. Si Penta 1, vous êtes à 77,4% des enfants n'ont pas pu avoir le Penta 1, je trouve que là, il y a vraiment un gros problème et par rapport même à toutes les épidémies qui peuvent aussi engendrer. Donc, voilà à peu près ma question. Et puis, la dernière question, voilà, par exemple, les activités vaccinales intensives supplémentaires, est-ce que le pays aussi font ça pour trouver ces zéro doses? Voilà peut-être ma question. Merci.
Okay, you can go ahead and respond.
Yeah, thank you so much for your question. And if I correctly say it again, is that you mentioned that and served children, they may study found that those children are concentrated in remote, rural, and nomadic populations, but not in the urban areas. But we use it secondary data, and the domain is that they categorize based on geography is urban, rural, and nomadic areas. And when we have tried to look how the zero dose children are distributed across all these three areas, it's found that it's more on concentrated in rural and nomadic populations. And we know it's true. There is a Boer community and there is a bucket of communities that are under immunized or zero dose children. But it's not into the level of the children that are found in the remote areas. That's one thing. The other aspect that it's very difficult for us to get in our secondary data is that there is a lot of internally displaced populations which are at high risk for having zero dose children or maybe under immunized. But our secondary data, it's very difficult for us to get exactly variable that we can maybe categorize our population into internally displaced or non-internally population. That's my answer. The second question is that although there are the zero dose children in Somalia is very high, and because of the even after the COVID, it's become even increased. This study was conducted, before, but there are a lot of actors that are involved, and there are a lot of strategies that has been used to reach the zero dose children and remote areas. Specifically, they tried to integrate other services like while doing the livestock service vaccination, so that they will provide vaccination along with the treatment of livestock. There is also areas where there is insecurity. So there is an approach that they use like healthy camps, so that they will mobilize teams who will go there and to vaccinate these communities. There are a lot of ongoing initiatives, but because of challenges in supply, demand, and maybe some issues regarding with some hesitancies that contribute low vaccination uptake in Somalia.
All right, thank you very, very much for that. The case of Nigeria, you showed 5% inefficiencies in one of the wards, I think, and it was because of a dispute. How much does politics play in the functionality of these ward development committees, because in my country we've got health center committees structured along the same lines, and a lot of local politics comes into play. Where people want to sort of gain political mileage using those structures. Sometimes, how common is that or rare in Nigeria?
Okay, thank you. So the issue of politics, it is generally happens everywhere, even at that level. So the inefficiency I showed was as a result of the WDC chairperson just thinking he can go into the facility and take anything they want. So that was what caused the rift with the officer in charge. But it's not supposed to be like that, because the WDC, they're supposed to be members of this community. And normally the chairperson is usually, say, a traditional ruler or a religious ruler, somebody of high standing within the community. So, but with regards to politics, yes, it happens and it plays a part. That's why there's a need to sensitize them. So when they get to that level, they understand that they are supposed to serve the community, and it's not selfish interest, or it's not a position to just feel like they're too big, right? So, but politics plays a part.
Thank you very much. Your issue about zero dose vaccination was solely centered around women. Do you think there's a role for their partners or men in pushing that agenda, or in making sure that the coverage can rise in your country?
Yeah, for our studies, more on relied on secondary data. We did not conduct any qualitative, so that maybe we can explore how the male contributes and even if they can take part on any issue. But as the literature is mentioning, they have sometimes influenced the decision making and on vaccination. Although sometimes they assume vaccination is part of the child care, and they obviously, delegate this issue to, or vaccination of these children to the mothers. And even sometimes, when mothers take their kids to the facilities, if they develop any side effects, sometimes it could lead some challenge within the family. So there are a lot of gender dynamics, not only the female, but also male can also play a role. But as far as what we get so far from our studies, that this is factors that come, stand, and outside of other factors that we get it.
Okay, so for example, I would want to understand how you measure the empowerment of a woman.
The empowerment of women, there was around 4 questions, and it's a standard questions that is asked while conducting DHS, and it was usually asked for mothers how they make their decisions when they want to, seek healthy, or maybe, but there was, I don't remember all of them, but there was a set of 4 questions, and we tried to combine and create a score of women environment based on the variables that were already included in the literature.
So I don't know if there's anybody in the room who would also want to. You don't have a mic there.
You can speak.
No, but the interpreters need.
Yeah, thank you, Said. I want to ask a question about the DPT. You have talked much about zero DPT and the first dose, is it? But I don't know what's the policy in your country. Is it a child supposed to be given only 1 dose? From my experience in Tanzania, we are supposed to have basically 3 doses of DPT. Yeah, so I think it was important for you to add the explanation regarding the DPT-3, because what do you know, like the research provide the evidence, and then there are policymakers and implementers that could want the evidence from you. So adding the information regarding DPT-3, because there are ones who are starting the first dose, but they cannot actually reach to the 3rd dose. So the 3rd dose, I think, it's more important to know that this percentage of children get the third dose and this one didn't for the effective actual vaccination. That's my question. For you.
Okay, and thank you so much. For our study, we use Gavi operational serodose definition, which states that serodose children are categorically known for children who did not receive the first DTB1. That's the definition that we use, and it's something even that's widely used by other studies. There is also another operational definition that maybe we could use, which is children who did receive vaccination at all, but it's not common. The most common type of definition that's used for serodose is those that don't receive the DTB1. For the DBT1 and DBT3, maybe that's for dropouts and something like that. But for the serodose definition, the most commonly used, antigen is DTB1.
Yes, so.
Excuse-moi.
Okay.
En tant que OMS, en fait, je confirme que c'est la définition de 0,12. C'est vraiment à partir de panta 1. C'est la définition de 0,12. Et quand on parle maintenant. Désolée, modérateur, je. C'est bon? Non, c'est juste, comme je disais, c'est juste pour confirmer que là, notre collègue disait que c'est la définition de Gavi. Effectivement, j'ai dit en tant qu'OMS aussi, je confirme, la définition des zéro doses, c'est vraiment l'enfant qui n'a pas eu le penta 1. C'est la vraie définition que nous devons aussi adopter. Parce que là, après, on parle de perdu de vue si c'est dans le penta 3 qu'on va évaluer. Donc, c'était juste pour affirmer, monsieur le modérateur. Désolé.
Yeah, I think that's a standard definition across all countries. But I mean, the results are very clear. You don't even imagine who would get to dose 3 if zero dose is so high. So it's I think the results are quite clear, right? I don't know if there's anybody else with a remark.
Oui. Peut-être ma dernière question par rapport à ça. Je suis un peu curieuse de savoir par rapport à l'épidémie qui sévit dans votre pays, en Somalie. Parce que effectivement, quand les zéro doses montent jusqu'à 77%, donc là, tout à l'heure, non, ce n'était pas dans notre session, là, par rapport à les rougeoles ou vraiment toute maladie évitable par la vaccination. Est-ce que vous pouvez en dire plus? Merci.
Yeah, thank you so much. Since the coverage is very low, and traditionally it's around 10% of the children who receive fully vaccinated against all the antigen, and some as much as around 74% of them did not receive the first DTB, and we are not expected, even if they don't receive the first one, they will not receive the rest. That's the expectation, and that's why how the Gavi definition come up. Because of that, it's very common, very frequently outbreak of measles, even across all the regions of Somalia. There is also diphtheria and other vaccine preventable diseases that is reported across all the countries in every year.
Okay, thank you very much. And I think in conclusion, what we got from these presentations on enhancing equity in vaccine access and also access to primary healthcare services is that there are a lot of issues currently, and they will be worsened by the current global geopolitics if we all don't adopt strategies that ensure that our services are patient-centric, they are integrated, they are comprehensive, they are continuous, and that our health workers are also able to do a lot of things that they might not have been able to do before because of this integration that will happen. And also that it's very important to carry out qualitative studies in the context that you are putting your interventions before you put them, so that you understand, or to identify a challenge and do qualitative studies so that you understand how you can get effective strategies from the people who are affected by either the condition or who are affected with the burden of disease, as we have seen with the rabies vaccine presentation. And I think it was the same as well with COVID-19 vaccination. I know in my country, first dose coverage was around 67%, and then second dose was 50%. Because some people who got COVID and were not very sick were now saying, this thing, you know, I don't have to go along with it. And some people, you would find that it's only those who had close family affected or died, and they got seriously ill, or their livelihoods were threatened if they couldn't move around with a certificate that would get also vaccinated. So I think it's very important, the qualitative studies that have been done, and also the issue of really looking at what are the determinants of access to these essential health services, especially vaccine preventable diseases, so that they can be addressed, so that you have you know, more access for the populations and more children being covered and more people being covered. So thank you very much for attending this session, and thank you very much to the presenters as well.
Yeah.